So hello everyone. So we listen to all the causes, all the things which can cause infectious, non-infectious, NMOs, multiple sclerosis. And now Dr. Jaspreet wants to discuss various case scenarios. I will just go through mine and then Dr. Jaspreet would take over. Now this is a patient, 2006, it's a long time ago, 37-year-old man who had pain in the left eye. So he went to an outside center, had disc edema, and as we heard that once you see disc edema, don't wait, just give steroids. So he received steroids, IV followed by oral, and then went to center B. Again, oral steroids were increased, but despite oral steroids, he developed decrease in the vision. Went to center C. They say, well, it could be posterior scleritis / optic neuritis, so undergoes MRI, and even pseudotumor was considered. His vision at that time was counting fingers, and the pupil was kind of iatrogenically dilated, undilated. Pupil, when it was seen left eye, he had RAPD. There was some flare in cells and minimal amount of vitritis. So he was seen by one of our trainees who saw him, and of course, it looks like disc edema, it looks like optic neuritis, even to me. So it was kind of thought of as optic neuritis. It's meant to be interactive case, but anyways, the fluorescein was done, and the fluorescein showed, nothing very remarkable, something you would expect in optic edema. There was inferior altitudinal hemianopia. The visual field was done by the resident, and he was told to continue on oral steroids because it looked like optic neuritis, to be very honest with you. Now, what happens? What was the major issue? The major issue is the periphery was not examined. You feel so happy looking at the field and looking at the optic nerve and the disc edema that you just feel lazy dilating the pupil, putting the patient on indirect ophthalmoscope, and actually bothering to examine because you don't suspect. So patient was lost for a month, and a month later, when he came on steroids, you can see these lesions which were there. So maybe these lesions were not this extensive when the patient was started on steroids. So you really have to take an effort. But if you remember, I showed you he had 1+ vitreous cells. So probably that means you have to make this extra effort. So what would you like to do now? We did the PCR, but that's more of an academic exercise. It's a very clear acute retinal necrosis, viral, received the treatment, prednisolone was tapered, and you can see over a period of time, this is a long time ago, we used to do laser at that time. Now we really don't do it all the time. So this is what it ends up with. So my only message I would like to give is before starting high-dose IV corticosteroids, like you check for your blood sugar or the blood pressure of the patient, please also make sure that you have examined the retinal periphery in detail, because these cases don't happen every day, but even if they happen once in the lifetime, they teach you a lot of lesson to be followed for the rest of your life. Thank you very much, and over to Jaspreet for other cases.